Hi everyone, Nurse Jenny here from Nurse Life Academy. We are going to be going over another comprehensive review today. And if it's your first time here, welcome. I would probably recommend starting with the individual systems since I do go into more depth with explanations. But if you want to stay here along for the ride, whatever floats your boat. I would greatly appreciate it if you liked and subscribed to my video if you found it helpful. And as always, please ask me questions if you need anything. Let's get started. Question number 1. The ABG on an intubated 60 kilogram patient during an episode of acute respiratory failure is a pH of 7.43, a PCO2 of 34, a PO2 of 84, and a bicarb of 25. The patient is on a rate of 12, tidal volume of 650, FiO2 of 60%, and a PEEP of 5. The most appropriate action should be to A. Increase the FiO2, B. Decrease the rate, C. Decrease the tidal volume, or D. Increase the PEEP. And the answer is C. Decrease the tidal volume. So there are a lot of numbers here, but that is okay. Let's just work through them. The way that I would approach this question is by looking at all the values and figuring out what is abnormal and going from there. So let's start with the pH of 7.43. That's normal. A PCO2 of 34 is slightly abnormal. PO2 of 84 is normal, and the bicarb of 25 is also normal. Looking at the vent settings, nothing looks super out of the ordinary on first glance. So what are we going to do here? It looks like we're going to need an intervention that increases our PCO2, so let's take a closer look. We can certainly get rid of two answers from the get-go. So an increase in FiO2 or an increase in PEEP wouldn't be necessary since the patient's PO2 of 84 is totally normal and does not reflect any hypoxemia. So now we've narrowed down our answers to B or C. And just a little bit of a pointer that I want to say, if you have a question that gives you the patient's weight in kilograms and ventilator settings, it should probably alert you to be looking at the tidal volume. Not in all cases, but just a little tip. So decreasing the rate seems like an easy way to increase the PCO2 since the patient will breathe less frequently, thus increasing the CO2 level. But we also know that decreasing tidal volume also increases PCO2. So which one are we going to choose? Well, we're going to have to do a little bit of math to choose the right answer. So this patient is 60 kilograms and is getting 650 milliliters of tidal volume per breath. And if you divide the two numbers, that is actually more than 10 milliliters per kilogram. And that is over the general recommendation of 6 to 8 milliliters per kilogram. So this is too much for the patient. So while decreasing the rate would help that PCO2, decreasing the tidal volume is actually going to be the best answer here because they are getting too much tidal volume for their weight. So I'm glad we did the math because I feel a lot more confident in my answer. So remember, if you have a patient's weight and vent settings, take a look, do some quick math, and figure out if the tidal volume is appropriate for that patient. So just like I mentioned in the last slide, generally tidal volume will be 6 to 8 milliliters per kilogram, and that is determined by the patient's ideal body weight and the medical problem. But remember, for a patient in ARDS, we want to have that lower tidal volume, so you're looking at a little bit closer to 4 to 6 milliliters per kilogram. Question number 2. Upon completing admission paperwork, your 71-year-old male patient mentions that he has mitral valve stenosis. Based on this information, you would anticipate which of the following findings? A. A systolic murmur and sinus bradycardia. B. a systolic murmur and atrial fibrillation, C, a diastolic murmur and atrial fibrillation, or D, a diastolic murmur with sinus bradycardia. So the right answer here is a diastolic murmur with atrial fibrillation. So murmurs of stenosis occur when a valve is open. So when is the mitral valve open? It's open during diastole when the ventricle is filling up with blood. So you're going to have a diastolic murmur. And you may anticipate the patient to have a fib because chronic resistance produced by stenosis of the mitral valve will result in an enlarged left atrium, which can lead to AFib. I wanted to do a quick review of valves because we haven't really covered it in any of the lectures, and I think it's important to know for the exam and for real life. Let's start out with understanding what is happening with the heart during diastole. So during diastole, the ventricles are filling with blood. And what happens during systole? The ventricles are going to be contracting during systole and they're pumping out the blood. So diastole, filling, systole, pumping. So when we are pumping out blood, it would make sense that our aortic valve would be open, right? So that blood can pump out of this left ventricle into the aorta and out to the rest of the body. Well, if we know that the aortic valve is open during systole, then it must be closed during diastole. And then the opposite would be true for the mitral valve. It would make sense that the mitral valve would be open during diastole so that blood can come from the atrium and fill that ventricle, and then it would be closed during systole when the heart pumps. So with that being said, let's talk about heart murmurs. Murmurs occur because there is either stenosis or there is regurgitation. And regurgitation is interchangeable with the word insufficiency. So if you see one or the other, know that they mean the same thing. So in stenosis, the valve does not open properly and it is stenosed. It is narrow, like in the turquoise picture here. I like to remember this by telling myself, in stenosis, the valve is open. And then in regurgitation or insufficiency, the valve does not close properly. So there ends up being backward flow through incompletely closed valves. So remember, stenosis, the valve is open. Let's put all of that information together. Let's start with mitral stenosis. We know that in stenosis, the valve is open. So when is the mitral valve open? The mitral valve is open during diastole. Let's do mitral regurgitation now. So we know that regurgitation happens when the valve is closed. When is the mitral valve closed? Well, if it's open during diastole, it has to be closed during systole, right? But also it makes sense because the mitral valve is closed when the heart is pumping. How about aortic stenosis? So stenosis is when the valve is open. When is the aortic valve open? It's going to be open during systole, when that blood needs to pump out of the aortic valve and into the aorta and the rest of the body. And so that means that aortic regurgitation, when is the valve closed? It is closed during diastole. So you may have noticed that the two valves are opposite of one another, and then the stenosis and regurgitation are opposite of one another as well. Technically, if you memorize one, you can figure out all the rest. And of course, me with my little acronyms, I have one for this. This one is not as appropriate, but I memorize it as ASS. So you know what that spells. So aortic stenosis is a systolic murmur, and that means that aortic regurgitation will be diastolic, because remember, one happens when the valve is open, one happens when the valve is closed, and the mitral valve will be opposite of the aortic valve, so mitral stenosis will be diastolic, which means that mitral regurgitation is systolic. If you memorize it with my ASS acronym, aortic stenosis is a systolic murmur, that is great because you can then figure out the rest of the three. However, I do strongly encourage you to understand the why and double check it by thinking through it. Okie dokes. Question number 3. A patient does not have decisional capacity at this time. His significant other has been at the bedside since his admission. His estranged wife arrives and demands that the significant other not be allowed to visit or be given updates. The nurse should A. Ask the provider to allow the significant other to have visitation privileges. B. Request a multidisciplinary care conference to discuss visitation and communication of patient status. C. Contact the hospital's medical legal department and request that the hospital attorney speak to the wife. Or D. Tell everyone that they must figure this out amongst themselves. And the answer here is B. Request a multidisciplinary care conference to discuss visitation and communication of patient status. This question wants to ensure that you are providing care that is consistent with caring practices, advocating for the best interests of the patient, especially if he does not have decisional capacity at this time, and exhibiting high levels of moral agency. It also wants to make sure that as a CCRN nurse, you are taking initiative and not just letting someone else handle the situation without being involved. These questions can definitely be tricky, and I would recommend doing a lot of the practice questions, read the rationales to help you understand patterns in what they're looking for. Question number 4. Which physiologic change should a nurse anticipate when caring for a post-operative patient with morbid obesity? Is it A, a decreased functional residual capacity, B, increased chest wall compliance, C, increased dynamic lung volumes, or D, decreased abdominal pressure? And the answer is A, a decreased functional residual capacity. So in a patient with morbid obesity, the only correct answer here is the decreased functional residual capacity. The other choices are not correct. And functional residual capacity is the amount of air remaining at the end of a normal exhalation. So in someone with increased adipose tissue in obese people, it is reduced because of their size and this adipose tissue around the ribs, the abdomen. That leads to increased pressure on the diaphragm, which leads to a decrease in thoracic volume, which would be a decreased functional residual capacity. Question number 5. A patient in HHS is being admitted with dehydration and a serum glucose level of 828 milligrams per deciliter. Which additional laboratory findings should the nurse anticipate? A, a decreased BUN, decreased creatinine, and elevated serum osmolality. B, an elevated BUN, a decreased creatinine, and a decreased serum osmolality. C, a decreased BUN, an elevated creatinine, and a decreased serum osmolality. Or D, an elevated BUN, elevated creatinine, and elevated serum osmolality. And the answer here is D, an elevated BUN, elevated creatinine, and elevated serum osmolality. With dehydration, you are going to see an elevated BUN and an elevated creatinine. And in HHS, you are going to have an elevated serum osmolality due to the hypovolemia. The most important thing I want you guys to know is that these patients in HHS are profoundly hypovolemic. They are going to be dehydrated and dry. And one of the differentiations between DKA and HHS is the markedly high serum osmo of these patients. Here is my little DKA versus HHS table. All right, question number 6. Which of the following patients has the least resiliency? A, the 80-year-old male with a STEMI but no comorbidities. B, the 48-year-old female with multiple fractures and hypertension. C, the 78-year-old female with a lung cancer and sepsis. Or D, the 59-year-old male with DKA and drug abuse. What is resiliency? Resiliency is about bouncing back, and we need to look at all of the factors that contribute to this. So that includes age, acute illness, chronic illness, and support systems. So given that, which of these patients would have the most trouble bouncing back? Probably the 78-year-old female with lung cancer and sepsis. Again, do a bunch of these practice questions on the ethics and professional caring side so that you familiarize yourself with the patterns and the verbiage. Question number 7. A patient with hypertrophic cardiomyopathy would have which of the following medications as part of their regimen? A, vasopressors and beta blockers. B, vasopressors and inotropes. C, beta blockers and cardiac glycosides. Or D, calcium channel blockers and beta blockers. In hypertrophic cardiomyopathy, remember that we have an enlarged septum that leads to a small left chamber size. So we have a filling problem of that left ventricle. And our goal is going to be to slow down the heart rate to maximize the diastolic filling time. So which of these medications would accomplish slowing down the heart rate and maximizing the diastolic filling time? It would be the calcium channel blockers and the beta blockers. Question number 8. A 24-year-old man has been diagnosed with acute kidney injury as a result of severe hemorrhaging after a motor vehicle collision. Which of the following would be expected laboratory values for this patient? Would it be A, a low urinary osmolality and a high urinary sodium concentration? B, a high urinary osmolality and a high urinary sodium concentration? C, a low urinary osmolality and a low urinary sodium concentration? Or D, a high urinary osmolality and a low urinary sodium concentration? The answer is D, a high urinary osmolality with a low urinary sodium concentration. With this patient, what kind of renal failure are we looking at here? Is this a pre-renal, an intrarenal, or a post-renal picture? With the information that we're provided, I would focus on the severe hemorrhaging aspect, which leads me to believe that this is a picture of renal hypoperfusion. So this would be a pre-renal failure. And in the case of hypoperfusion, the kidneys are like, whoa, there is not a lot of volume here. So let me hold on to all of the water and sodium that I can get my hands on. It's going to conserve the sodium and conserve the water, so there is not going to be a lot excreted into the urine. And that is what's going to lead to the low urinary sodium concentration. And then if the kidney is holding on to this water, a little bit is going to be excreted into the urine, so it is going to be concentrated and the osmolality will be increased. Here's my little table comparing the different kind of kidney injuries. Question number 9. Abdominal pain, abdominal distension, diminished bowel sounds, fever, and leukocytosis after bowel resection is likely an indication of which of the following? A, an anastomosis leak, B, pancreatitis, C, bowel obstruction, or D, fistula. The answer is A, an anastomosis leak. These types of symptoms after a bowel resection surgery most likely indicate that there are GI contents leaking into the peritoneal cavity, also known as an anastomosis leak. We are looking at symptoms here of peritonitis, which are very serious and go hand in hand with an acute abdomen, which requires immediate surgery for a washout. Question number 10. A patient just had a permanent dual chamber pacemaker placed and is in atrial fibrillation. Which of the following would be the most appropriate pacing mode? A, DVI, B, DDD, C, VVI, or D, AAI? The answer is C, VVI. So while it is a dual chamber pacemaker, if they are in AFib, are you going to want to pace the atria? You don't really want to pace the atria because they're in fibrillation, right? So it's just going to be all over the place and it may or may not even pick up. So you would want to pace this patient in VVI. Let's quickly go over the 3-letter code for pacemakers and the ones that we'll see the most. The first letter refers to the chamber that is paced. So this is going to be A for atria, V for ventricle, or D for dual, which means both the atria and ventricles. The second letter is going to be the chamber that is sensed. So second, sensed. And again, that will either be the atria, the ventricle, or both. And the third letter is going to be the response to the sensing. So generally, we will want to inhibit the response if there is an intrinsic beat that is sensed. The D will only be used when the first 2 letters are D, since it will both trigger and inhibit. Or we can do nothing, which is O, and that is usually never the case. The most common modes are going to be VVI, AAI, or DDD. So thinking about VVI really quickly, the first letter is the chamber that is being paced. So we're going to be pacing the ventricle. The second letter is going to be the chamber that is sensed, which is also going to be the ventricle. And the third letter is going to be our response to the sensing. I, meaning inhibited. So that means that if there is a ventricular activity that is sensed, the pacing is going to be inhibited and it will not fire at that time. So that makes sense, right? If the heart is beating and the pacemaker sees that, it will not fire at that time. Another thing of note here is that transcutaneous and transvenous are only pacing in VVI. Question number 11. Which of the following is the most likely fatal event in disseminated intravascular coagulation, or DIC? Is it exsanguination, B, intracranial hemorrhage, C, myocardial infarction, or D, cerebral thrombosis? The answer is B, intracranial hemorrhage. It is the most likely fatal event, and it is related to the severe thrombocytopenia and depletion of clotting factors in DIC. Remember that DIC is a clotting problem, not a bleeding problem. Question number 12. Which 12-lead EKG changes should be expected in a patient with ACS, acute coronary syndrome, involving the inferior wall? Would you see A, ST segment elevation and deeply inverted T waves in leads V4 through V6, 1 and AVL? B, ST segment elevation in leads 2, 3, and all the precordial leads? C, ST segment elevation and deeply inverted T waves in leads 2, 3, and AVF? Or D, ST segment depression and T wave elevation in leads 2, 3, and AVL? The answer is C, ST segment elevation and deeply inverted T waves in leads 2, 3, and AVF. So remember, inferior is 2, 3, AVF. What are we also thinking about when we have an inferior MI? What kind of complications? Well, you can definitely have a RV infarct, a right ventricular infarct, and papillary muscle rupture, and a third-degree heart block. All right, question number 13. Which ABG results indicate acute respiratory failure? A, a pH of 7.24, PCO2 of 54, PO2 of 55, bicarb of 22, and SpO2 of 76. B, a pH of 7.22, PCO2 of 48, PO2 of 82, bicarb of 12, and an SpO2 of 92. C, a pH of 7.52, PCO2 of 28, PO2 of 76, bicarb of 30, and a SpO2 of 82. Or D, pH of 7.36, PCO2 of 24, PO2 of 55, bicarb of 16, and SpO2 of 70. And the answer here is A. So acute respiratory failure is defined with ABG results of a PO2 of less than 60 and a PCO2 greater than 45. Question number 14. A male patient with a known history of Wolff-Parkinson-White or WPW syndrome developed pre-excited atrial fibrillation at 190 beats per minute. The nurse should anticipate the administration of which of the following medications? Is it A, adenosine, B, diltiazem, C, esmolol, or D, digoxin? The answer here is C, esmolol. In a patient with Wolff-Parkinson-White, we're going to talk about how they have an accessory pathway, and beta blockers are going to be your best medication to give. We do not want to give adenosine for WPW syndrome. So Wolff-Parkinson-White syndrome, it is a pre-excitation arrhythmia, and it is a congenital defect that creates this abnormal conduction pathway between the atria and the ventricles. So in a normal heart, like we see on the left side here, we have our SA node, which tells the atria to contract. Then we go to the AV node, which slows down that impulse and brings it to the ventricle, causing ventricular contraction, and your heart is happy. In a Wolff-Parkinson-White pathway, shown on the right side here, you're going to notice that there is this accessory pathway in green, and this pathway conducts faster than the AV node, which can lead to rapid ventricular rates. What I want you guys to know is that Wolff-Parkinson-White is an abnormal conduction pathway between the atria and the ventricles, and it is a form of paroxysmal supraventricular tachycardia, or PSVT. And with Wolff-Parkinson-White, you will see a short PR interval with this PSVT, and there is going to be a delta wave. This picture shows a delta wave. It looks like a little curve after the P wave and into that R wave. You don't need to know what it looks like, but I do want you to remember that there is a delta wave present with Wolff-Parkinson-White. Lastly, your go-to medications are going to be beta blockers. Unlike other forms of SVT, you don't want to use adenosine because it can put the patient into a lethal arrhythmia because of this abnormal pathway that's there. At one point or another, you will definitely need an ablation here just to minimize your risks of going into anything like this, but definitely avoid adenosine and use beta blockers. Question number 15. A patient is admitted with a fever and nuchal rigidity. Which findings from the lumbar puncture most likely indicate bacterial meningitis rather than viral meningitis? Is it A, CSF glucose of 30 milligrams per deciliter, B, CSF with elevated WBCs and protein, C, a fever greater than 40 degrees Celsius, or D, a decreased level of consciousness? The answer is A, a CSF glucose of 30 milligrams per deciliter. So viral meningitis will not lower the CSF glucose, but bacterial meningitis absolutely will. Remember that bacteria love to eat sugar, resulting in a lower CSF glucose than normal, which is generally 50 to 80. The other three choices could be seen with both bacterial meningitis and viral meningitis. Usually the CSF glucose will be one of the differentiating factors. All right, question number 16. You are reviewing the lab results of a patient who was admitted with a stroke and a history of thyroid disease. The lab results include a sodium of 118, elevated TSH, and elevated LDH and CK. Which of the following might you also see? A fever, B, tachycardia, C, elevated T3 and T4, or D, respiratory depression and hypoxemia? The right answer here is D, respiratory depression and hypoxemia. The one thing that should stick out to you is the history of thyroid disease and the elevated TSH. So what do we have here? Do we have hypothyroidism or do we have hyperthyroidism? It doesn't tell us. But since the TSH is elevated, that means that the body is trying everything in its power and it's working overtime in order to try to stimulate the thyroid. And this means that the patient probably has hypothyroidism. On top of that, the patient had a stroke, which is a huge stressor on the body that exacerbated their hypothyroidism. So to answer this question, what do we know? We know that the patient has hypothyroidism, and in hypothyroidism, everything is slower. Do you guys remember the name of the most severe form of hypothyroidism? It is myxedema coma. In hypothyroidism, everything is slower. And in myxedema coma, the slow metabolism symptoms are going to be so severe. Everything is going to be slowing down. Everything is going to be slow and cold. You're going to see things like altered level of consciousness or decreased level of consciousness, disorientation, hypoventilation, hypothermia, bradycardia, slow, shallow respirations, all of that stuff. So D is going to be the right answer here. If worst comes to worst and you have no idea with this question, the odd one out is respiratory depression and hypoxemia. The rest of the three, fever, tachycardia, they show a high metabolism. And as for the elevated T3 and T4, we know that T3, T4, and TSH are always going to be inverse of one another. So you wouldn't see an elevated T3, T4 in this patient. You would see the opposite. Question number 17. A patient admitted from the emergency department is unresponsive after a suspected heroin overdose. In assessing his pupils, you expect to find which of the following? A, bilaterally dilated pupils. B, unequal pupils. C, bilaterally constricted pupils, or D, nystagmus? The answer here is C, bilaterally constricted pupils. Opiate intoxication causes pupils to be bilaterally constricted or even pinpoint. Think about the patient you give fentanyl to for sedation. I hope that you're assessing their pupil reactivity even if they're small. And you'll generally see them smaller if you give them a fentanyl push compared to some other non-opioid medications. Question number 18. Hypoglycemia should be suspected when the diabetic has these symptoms. Is it A, increased skin turgor, abdominal pain, and tachypnea? B, flushed skin, tachycardia, and small breathing? C, thirst, hypotension, and fruity odor to breath? Or D, weakness, headache, and diaphoresis? And the right answer here is D, weakness, headache, and diaphoresis. The easiest way to remember the initial symptoms of hypoglycemia is to think about the effects on the sympathetic nervous system. Initially, the effects are going to be tachycardia, tachypnea, irritability, cool, clammy skin, diaphoresis, and weakness. And then eventually, headache also occurs as the glucose in the brain decreases. The other choices have some symptoms that throw you off, but they are mostly signs of diabetic ketoacidosis or DKA. So you'll see small respirations, fruity or acetone breath, decreased skin turgor, which is associated with dehydration, and abdominal pain. These are all symptoms of DKA, whereas D has symptoms of hypoglycemia. Question number 19. You are admitting a patient with hepatic failure. Which of the following treatments would you anticipate? A, provide higher doses of insulin to treat hyperglycemia. B, provide sedation with benzodiazepines. C, treat dehydration with lactated ringers. Or D, treat ascites with spironolactone or aldactone. The answer here is D. You want to treat ascites with spironolactone. With patients with hepatic failure, you don't want to do anything that increases their ammonia level. And a low potassium level actually increases ammonia production and it can result in acidosis. So we want to avoid hypokalemia. With spironolactone being a potassium-sparing diuretic, this is going to be our best answer. Looking at the other choices, patients with liver failure tend to develop hypoglycemia, not hyperglycemia, so we wouldn't give them more insulin. And then sedation should be avoided since it could mask encephalopathy. Lastly, we want to probably not give them lactated ringers because that can result in acidosis if the liver can't metabolize that lactate. So generally, you'd want to use 0.9 instead. Last but not least, question number 20. A patient is in early septic shock. Which of the following hemodynamic values would you expect? A, an SVR of 1400 with an EF of 30%. B, an SVR of 525 with a cardiac output of 9. C, an SVR of 1200 and an EF of 60%. Or D, an SVR of 600 and a cardiac output of 3. What is the answer here? It is B, an SVR of 525 and a cardiac output of 9. When I think about someone in septic shock, the first thing that comes to mind is hypotension. Why do they have hypotension? They have hypotension because they have massive vasodilation. And if you have vasodilation, your SVR is going to be low. So we can cross out A, we can cross out C. It's between B and D. Now, are we going to have a high cardiac output or a low cardiac output in early septic shock? Remember that early on, the sympathetic responses kick in, and that's why we're going to see a high cardiac output. All right, you guys, we have made it to the end. If you liked this video or found it helpful, please like and subscribe to my channel. I would greatly appreciate it. Let me know if you guys have questions. I'd be more than happy to help. And if you are taking your CCRN soon, good luck. You have totally got this. Put in the hard work. Take your time to study, understand the why. You all can do this. I know it. I believe in you. Thank you everyone for watching. Nurse Jenny signing off for Nurse Life Academy. Have a good one.